I got okay. So we are live. So I'm gonna get started in a minute. I'm gonna give people an opportunity to log on and share a few housekeeping slides before we get into our topic on understanding Medicare for transplant, as well as fundraising for costs not covered by insurance. So we have a really exciting topic. Finances around transplant are often requested because it can be very overwhelming. So I'm sure everyone will find this information very useful today. So I will get started. I am Talia Giordano. I am a licensed social worker and manager for our Family Services and Caregiver Lifeline program with the Gift of Life Family House in Philadelphia. Again, today's program is on understanding Medicare for transplant and fundraising for costs not covered by insurance. And we have a really great lineup of speakers. So housekeeping really quickly. So we are recording this program so that we can make it available to participants after. We want you to chat through the chat box, share your story. If you could share where you're calling in from. And we have some individuals both from Help Hope Live and CODA on the call today who specialize in fundraising for transplant. So if you have questions around that, you can ask them through the chat as well. Additionally, if you have questions for our speakers, you can do so through the Q&A box, and that's just easier for me to follow for the time when we do Q&A at the very end. And lastly, please consult with your transplant team or medical providers if you have any questions specific to your own transplant care. Just some upcoming webinars. So in October, we're going to have a transplant panel with patients who are going to share their experience around transplant. And then in November, we'll have a discussion on estate planning. I want to quickly thank our sponsors for today's webinar. So CSL Behring, if you've been on our webinars over the last few months, then you would have heard CSL sponsored all of our webinars for the year. So CSL is a global biotech leader driven by their promise to save and improve lives. Their ability to innovate and deliver life-saving medicines for patients with rare diseases and other unmet medical needs around the world has earned them a reputation for always putting patients first. They see a significant unmet need in transplant and are committed to delivering innovative solutions to address them. So thank you, CSL. And then today's webinar is also sponsored by Children's Organ Transplant Association, so otherwise known as CODA, which I had mentioned earlier. And I'm actually going to share a video that CODA provided. So bear with me because the video is actually going to take me to another website.
I am Rick Lofgren, president of the Children's Organ Transplant Association, or CODA. For more than 35 years, CODA has been the nation's leading organization providing fundraising assistance and family support to help children and young adults who need a life-saving transplant. In fact, CODA has raised more than $130 million to assist families with transplant-related expenses, while never charging a fee for our services. It's one of the reasons that we're known as a trusted leader supporting families. We look forward to helping you navigate your family's transplant journey.
Brenda, can you, since you're the only one on screen, did that show okay? I want to make sure that, okay, perfect.
Yes.
Okay, so thank you again, CODA, for sponsoring this webinar today, which is a perfect sponsorship and partnership today, since we're talking about finances and fundraising. Following this, we'll also send an email to everyone with an evaluation, as well as multiple resources for both the financial aspect as well as fundraising resources. So please look in your email for information from us about fundraising through CODA, as well as Help Hope Live, which you'll hear a little bit about with our adult recipient today. Oh, wrong one. So I'm going to stop sharing right now so Brenda can share. So Brenda is a lead transplant financial coordinator with Thomas Jefferson Transplant Institute in Philadelphia. She has many years experience on this topic. So we're really happy and excited to have her with us today. So Brenda, you can share your screen. I'm going to go off screen and thanks again.
Okay. You have my slides?
I don't. So if
Okay,
you
I
want
got
to
them.
share, okay, great.
1 second. I just have to pull them up. I'm sorry.
That's
I should have
okay,
actually done
no.
it before.
No, take your time. And it looks like there are people calling in from all over the country so far. So thanks everyone for being here.
Okay. One second.
It's okay. Oh, I see someone's from Kentucky. That's pretty far. Brenda, I could share them if you'd like. It's totally up to you.
Yeah, I'm having trouble finding them. 1 second.
Okay, I think I have them in my recent email from you.
Yeah, that's what I was looking for.
Let's see. And I did email the slides out to everyone as well, so that you can, if you wanted to take notes or access them later, you can do so. Sorry for the delay.
Yeah, my system's moving a little slow.
I know that always happens at times like these. Okay, I found them. Okay, so I'll reshare my screen, and Brenda, you can just let me know
Awesome.
when to move forward.
Yep.
Here we go. You can see them?
I can.
Okay.
Okay. Awesome. Again, ladies and gentlemen, I'm Brenda Davis from Jefferson Hospital Transplant Department. I've been here, actually, I've been a financial coordinator for approximately almost 22 years next month. So I know the ins and outs and the financial aspects when it comes to transplant finance. Okay. You can move to the next slide. Okay. There are many reasons for being entitled to Medicare, and it's not specific to anyone. It's based on work history. It takes approximately 40 years to accumulate enough work units to qualify for Medicare, and you gain 1 unit of per quarter every year. So four units per year. So approximately it'll take about 10 years to accumulate enough work units to actually qualify for Medicare benefits. That's if you're working full time. If you're working part-time, it takes twice as long, because you're just taking twice as long, of course, to accumulate those work units. You can skip to the next one. When it comes to kidney dialysis, kidney transplant or dialysis, your Medicare entitlement, again, first is based on work history, but the count starts for qualifying the 4th month of hemodialysis. So if you start hemo in January, no matter what day of that month, your entitlement to potential Medicare starts that 4th month of your hemodialysis. Should you be a PD or peritoneal dialysis patient, your Medicare entitlement count starts actually the month of peritoneal or PD dialysis. You're referred to by your dialysis social worker to Social Security, so that the Social Security office can actually do the assessment to see if you're actually entitled to that Medicare benefit. And once you are eligible for the Medicare, Medicare is considered the secondary payer for the first 30 months. So if you have employer group insurance while you're on dialysis, or even at the time of transplant, once you become entitled to that Medicare, Medicare is the secondary payer for the first 30 months of your Medicare entitlement. The only way it would automatically become primary is if you had state insurance through Medicaid. Medicaid is always going to be the last payer of resort. So if that's your only insurance by the time you're entitled to the Medicare and have the actual eligibility, that's the only time Medicare is automatically the first payer. Okay, next slide. There are certain times of the year when you actually can apply for the Medicare benefit. The open enrollment that you hear a lot about around this time of year, this is the open enrollment that is only allowable for patients who are already on Medicare, have that Medicare A and or B benefit, and they want to make changes to that benefit, whether it's to add a supplemental insurance, change your Part D pharmacy benefit, or switch to one of the bundled Medicare plans that bundles the Medicare, medical, prescription, vision, and dental together. That's what the fall open enrollment allows patients who are already on Medicare to make changes to their current coverage. And whatever changes you make during that fall open enrollment, that new policy will begin on January 1st of the following year. Now, Medicare allows you to get to know that new insurance once the change happens in January. You have about 3 months once you use that new plan to decide whether or not it's something you want to stay with. If you decide that you want to go back to what you previously had the previous year, Medicare actually allows you to do that as long as you make that change by March 31st of that next year. It used to be years ago, you had until mid-February, February 15th, to get to know your new policy and decide whether or not you wanted to keep it. But unfortunately, lots of people don't have any services incurred during that 6-week period. So Medicare decided to extend that time frame to allow patients to actually get to know the coverage and decide whether or not they want to keep it for that particular year. Okay, next slide. Okay, as I alluded to a few slides ago, where Medicare entitlement makes you eligible for the Medicare, but Medicare again is not going to be primary for the first 30 months. This is the Medicare eligibility rule. It's not transplant rule, and it's not commercial insurances rule. So commercial insurances have to follow the Medicare guidelines, and Medicare dictates that they're not going to be primary for the first 30 months. It's really important for transplant teams as well as dialysis to re-educate patients and reiterate to them so that if they opt out of purchasing the Medicare at the time of the actual Medicare entitlement, they can pick it up later on in the year or the following year, but they need to be reminded to do that before the end of their 30-month COB period, because they can't do it anytime throughout the year. There's a certain time of the year where patients can actually enroll into the Medicare A and B. So that is on file by the time the order switches and Medicare becomes primary. Now, the one thing patients should really know is that if you don't enroll into the Medicare and you meet your 30-month COB period, where Medicare becomes a primary payer, it doesn't matter if that patient enrolled into Medicare when they should have. If that commercial insurance knows that the order switches and they know that they should be the secondary payer at that time, they can deny claims altogether or pay as though Medicare were already on file as the primary payer and only reimburse at the 20% balance that Medicare would have left behind. So it's really important to not just have that conversations with patients in front of the evaluation process, but throughout and again as they approach their 30-month COB period. Okay. Oh, I guess I'm a little bit ahead of myself. Again, should a patient not enroll into Medicare by the end of their COB period, they would be considered underinsured and not eligible for the transplant at that time. Because again, we know how the insurance is going to work, and we don't want a patient penalized for not enrolling into that Medicare A and B timely before the transplant happens or before the Medicare becomes primary. And honestly, if a donor is being considered by that recipient, the recipient themselves need to be transplantable at the time that a donor is being considered. There's no point of working up a donor if a recipient is not going to be ready based on insurance. Okay. And then once that Medicare becomes primary, depending on when the patient actually gets this transplant, Medicare is likely only going to be primary for just a few months for them, because the Medicare that's entitled based on ESRD dialysis or the kidney transplant itself, that entitlement goes away 3 years after a successful transplant, if you're still under the normal age of Medicare entitlement, which right now is still 67. But then and this is very specific conversation that you have for each patient based on their own scenario, okay? And then a patient could be entitled to their Medicare again, should they either need another transplant, are diagnosed with another qualifying disability, or becomes the legal retirement age of 65. Next slide. Entitlement is the same as we mentioned previously, but there is a difference. It is different when a patient becomes eligible for Medicare benefits. If your Medicare is approved based on disability, not ESRD or kidney transplant, there's a 2-year waiting period before that Medicare entitlement, Medicare eligibility. You're entitled to it based on a disability, but the eligibility, there's a 2-year waiting period for that. So patients that don't have ESRD or don't have a kidney transplant find themselves waiting for that Medicare benefit for at least 2 years. But once the Medicare is effective, it could be primary or secondary, depending on what other insurance that non-ESRD or non-kidney transplant patient has. But again, very specific to the patient's situation at that time. Next slide. Okay, normal entitlement, again, when somebody comes to legal age of retirement or age 65 currently, they're entitled to Medicare benefits, again, also based on work history. If someone, that recipient, Medicare recipient or a spouse is still working at the time they become entitled to Medicare based on normal age, then it really would, Medicare is usually the secondary payer, depending on the actual employer group size. I actually have a cheat sheet that I utilize for myself and my other financial coordinators, so we can best communicate to a patient as to which plan is going to be primary or secondary. It's really specific to the reason for having the Medicare and the employer group size. Some employers offer their medical benefits beyond retirement. We have a plan, we have a couple groups that offer it for up to 5 years after after retirement, or for a lifetime. And again, it's really going to be very specific to why the patient has Medicare in the first place to determine who's going to be the permanent payer, who's going to be the primary payer. But patients are always encouraged to get Medicare A and B at the time of retirement, so that they don't face any potential penalties later on. Because even though you're carrying your employer group benefit for maybe 5 years, there could still be a penalty for not choosing that Medicare B at the time of retirement. You often, if you pick it up at the end of that benefit period that your employer is extending it, you could find yourself facing a penalty for not choosing Part B when you should have. Okay. And that leads us to this segment. If someone is to opt out of playing Medicare B because their work extended a benefit to them for a period of time, the penalty for not choosing B when they retired is usually 10% on top of the monthly premium for every year that you did not choose the Medicare. So if your work offered your benefits for up to 5 years after transplant, so you're looking at 10% monthly premium times 5 for every year that you did not choose the Medicare benefit when you should have. For ESRD patients, again, that Medicare primary is at the end of that 30-month COB period. Okay, next slide. For disabled or normal entitled patients, this is when Medicare should be the primary payer. The patient or spouse loses credible coverage through active employment, then you have another opportunity to apply for that Medicare A and or B, because someone losing an active employer group is considered credible coverage. But again, the key words is active employer coverage. If someone is on a COBRA benefit, COBRA is not active employer group, therefore not considered credible coverage. It's good coverage, but not considered credible coverage and doesn't qualify you for special enrollment to enroll into Medicare A and or B. It's really important to know when to do that. So a consistent education is very, very key. Next slide. There are some important dates that every Medicare patient, whether they have that benefit, should know about. The general enrollment that starts January 1st and runs through March 31st. This is that time of year where if you're entitled to Medicare A or B and did not enroll during the year when you could have, this is the time to pick it up. If you enroll during this period for the Medicare A and or B, the benefit doesn't start right away. It will not begin until July of that very year. So it's important to plan this timely with either your dialysis social worker or your transplant financial coordinator. But once you become Medicare eligible, for whatever reasons, when you're brand new to Medicare, you have a 6-month period where you actually have time to get a supplemental plan or Medigap plan to coordinate with your Medicare A and B, or choose a Medicare Advantage plan that bundles all of the medical, the pharmacy, and the other benefits that traditional Medicare does not cover. Okay. Next slide. Another important date, dialysis social workers are well aware of the 30-month rule. When a patient is entitled to the Medicare, whether they apply for it or not, it's just really important to reiterate to a patient when it is appropriate for them to apply for that Medicare benefit, should they opt to hold off on enrolling. And the main reason that people hold off on applying for the Medicare B is because Medicare A is based on that Social Security tax that you've been paying throughout your work history. So it does not come with a monthly premium. So getting Medicare A doesn't penalize you to do. It doesn't cost you anything. People often hold off on B until Medicare becomes primary, because Medicare B does come with a monthly premium. And the average premium right now for people whose income is under $85,000 a year, that monthly premium is approximately $148 a month. So people opt out of paying that monthly premium if they have good employer group coverage, because Medicare likely is not going to get reimbursed. Now, if your income is greater than that 85,000 threshold, and that's household income, so it doesn't matter if it's just your sole income or yours combined with a spouse, the monthly income cutoff where the premium is under $150 is 85,000. There are some patients who have income greater than that amount, and you'll find that that monthly premium for the Medicare B is much, much greater than the 148. And there is a scale on the Medicare website that tells you how much your premium could be based on income. Okay, but that's the main reason that many people opt out of Medicare B. It's just really important for the teams, the dialysis unit and the transplant centers to work together so that the patient is aware of when they should apply for that Medicare B benefit, so that they're not penalized for not doing it timely. Okay, and again, like I said earlier, insurance companies knows they're paying claims just like Medicare would be. So they know at some point, if they're paying dialysis claims, that they are going to be the secondary payer, and they are going to penalize a patient for not enrolling into B for whatever reason. Okay. Most people are entitled to Medicare due to ESRD, end-stage renal disease, kidney transplant, whichever comes first. We actually have patients who get a kidney transplant before they ever have dialysis. So that's another opportunity for patients to get the Medicare A and or B. But again, we do have a number of patients who will opt out of B and pick it up just before the Medicare is going to become primary, so that when the order switches, there's no penalty for them. But if Medicare is based on dialysis, then again, if it's hemodialysis, your entitlement is month 4 of dialysis. If it's PD dialysis, peritoneal, that Medicare entitlement is the very first month of your PD dialysis. Okay. Some of these seem redundant, but it's really good pointers for people who don't understand insurances. Again, if Medicare is based on kidney disease only, then that Medicare is entitlement is only 3 years after you receive your transplant. If you're on dialysis for 5 years, that 36-month count does not start until you actually receive a successful kidney transplant. So 3 years after that transplant, if there is no other disability and you're under the age of 65, that Medicare will end, because the only reason you were entitled was ESRD or the kidney transplant itself. If you have another disability or turn 65, then Social Security makes that determination on whether or not your Medicare will continue. But likely it will, based on a non-ESRD, non-kidney transplant diagnosis with your normal entitlement. But the order of who's primary or secondary could switch. Okay. We have programs locally in our area for patients who require assistance with paying for post-transplant medications or other medications that are related to a kidney transplant or other disabilities. In New Jersey, it's called PAD. That's pharmaceutical assistance for the aged and disabled. And everything comes with an income guideline, but the threshold is pretty generous for our disabled patients and retired patients. And there's another level of that program that allows patients to have a little bit more of income than the PAD, called Senior Gold. You don't have to be 65 years of age to apply for the PAD. You just have to meet the income requirements, be a disabled resident of the state of New Jersey. The Senior Gold, you do have to be at least 65 years of age and meet the other requirements. And these programs are helpful for patients who have some of those Advantage plans, who have a Part D attached. However, the anti-rejection meds post-transplant are not processed through that Medicare Part D. They have to process through the Medicare Part B, and Part B is only 80% coverage. Years ago, they used to write off at 20%, realizing that these patients switched to a Medicare Advantage plans for the convenience. However, throughout the years, they've reduced that. They stopped the write-off altogether, and that it allowed some of the copay to fall towards patients. Now they actually allow the full 20% to fall to the patient. So if a patient doesn't have some of these pharmaceutical assistance programs, they're stuck with the 20% of that for the anti-rejection meds. However, with one of these programs, it could reduce that cost share down to $6. And these plans actually roll over annually as long as the patient continues to meet the income guidelines. In the state of Pennsylvania, we have something called chronic renal. Same type of program, does the exact same thing, assist with patients 20% should they need them. Many of our patients who have a Medicare A and B plan and a supplemental plan, many supplemental plans will pick up that 20%, depending on the plan letter that the patient is enrolled in at the time of the transplant. But there are some of the plans, not all the plans will pick up that 20% excess charge, and that will leave the patient with that 20%. But being eligible for one of these pharmaceutical assistance programs helps significantly. Our Pennsylvania program does require a patient to reapply annually, but the New Jersey plan does not. Next slide. Okay. For some of our patients on dialysis who cannot maintain the monthly premiums for their supplemental insurances, are often covered through the American Kidney Fund. This program covers the premiums for those supplemental plans, or actually they pay for premiums for some COBRA policies. And also some of the ACA, Affordable Care Act plans. The Kidney Foundation has decided to maintain the premiums for these patients. They used to stop it right after transplant. However, now they are covering these payments for the patients throughout the rest of the year in which the patient receives the transplant. And this is very helpful for many of our patients because it allows them time to try to figure out how they'll be maintaining the premiums themselves after they're transplanted and the American Kidney Foundation stops paying for these programs. Okay, next slide. Okay, this is where I fall off, and Talia, you pick up.
I think we're actually going to skip over those slides because we have another webinar. Yeah, so not to take up too much time related to the financial piece.
Mm-hmm. You can skip these.
Oh, okay, got it.
This is more of the social worker slide.
Oh,
yeah, you can skip the rest of these.
Oh, all of them. Okay.
Yeah.
Okay, great. So I'm going to stop sharing. There are lots of questions, but I think we're going to hold off until the end to go through all of the questions. So now I am going to invite our two panelist speakers. So Brenda did a really fabulous job of talking about Medicare related to transplant, but there's still many costs that are not covered by insurance, including Medicare. So we've invited two additional speakers. So Melissa and Bill, if you guys want to turn your cameras on. There are two Melissa is the mom of a heart recipient, and Bill is a heart recipient himself. And I think Melissa's here. She is here. Melissa, oh wait, maybe you can't. I'm not sure if you can turn your video or not. Melissa, oh, there you go. Sorry. I think it was my fault. So we're going to have a little chat with Melissa and Bill about their experience with fundraising and why it's a really important resource that transplant patients and families should really consider. So, and then we'll do a full Q&A at the end with all of our speakers today. So in no particular order, Melissa or Bill, can you share very quickly just a little history about your transplant journey?
Melissa, you want to go first or shall I?
Go ahead, Melissa.
Thank you. First, I want to say thanks to all our previous speakers. I know that Brenda and Charles and they were amazing. So I just want to say thank you for that. I will go ahead and start kind of our journey. We started with transplant when my son was born with cardiomyopathy. He needed a transplant about 8 months later. We had to travel out of state for that. We were so thrilled to hear that there was another option to help us with those funds once he was listed. Before that, we were very afraid of what would happen. He wasn't on Medicaid yet. We didn't know about that program. We were just existing basically on my husband's health insurance plan and donations, just well-wishers from our community. And as far as it goes and as much as it helps, it's kind of hard when you're bringing in millions of dollars worth of bills, which is overwhelming. And it's not like me and my husband did poorly for ourselves or anything like that. We were both programmers, and there was no way we were going to be able to keep up with the amount of bills coming in. So when we went to Dallas to have my son's transplant, and the social worker there told us about that we could fundraise and that we qualified for supplemental insurance through Medicaid with my son, that was a huge relief. As much as the dual insurance covers it, it does not cover everything. We ended up going with CODA because of our situation with Dylan, and they're great with kids. And so they helped us through that process for things that insurance wasn't going to cover, extra bills for travel expenses, for medical care, and basic necessities that we need to exist out of state, because my husband was back home in Phoenix and we were in Dallas at the time. So that was hugely helpful. They set us up with a website, they set us up with a community. I know the other groups that financially raise, they do similar things, and they try to take that pressure off of you, that financial pressure, so that you can focus in on the care of either yourself or your child in our case, because that's so important. It's really hard to have total health and healing when your interest and your attention's divided by how am I going to pay for any of this. I joke around, but it's kind of half joking. My husband had this plan to leave the country if we had to, so because it was so overwhelming. But thanks to the many people on our transplant team, our coordinator, the social work team that connected us with the resources that we needed, and it was very, very helpful. Even if you are traveling and out of state, they can still find a way to help you. And most of those funds, can sit and wait, at least for us. We use a lot of them, but we save a lot of them too for Dylan when he's older, because we know when that transition stage hits and he's kind of inherits all of this, his own care, his own bills, it's going to be just overwhelming. And so we hope that that'll give him just the start that he needs to have a successful adulthood with his transplant.
Thanks, Melissa. And the picture that's on the screen, I'm pretty sure it's a very old picture. So how old was he when he got his transplant, and how old is he now?
He was 8 months old when he got his transplant, 6 months old when he was listed. And that particular picture is us at evaluation. So that was the day we got to Dallas and we were being evaluated to be listed. So he was a sick little guy, but all the difference now, you would never know that he was, dying when he was younger, and that he took, 4 years to learn how to eat again, and a long time for all those therapies to take place. And a lot of it, thanks to the fundraising that we had, we were able to cover those expenses. He is 13 now, and at football practice, believe it or not, approved by his cardiology transplant team. I never would have dreamed to have hoped to see the day where he was playing a contact sport after all of this, but yet there he is.
Oh my God, that is so amazing. How wonderful. And 13, basically 12 years later. And you bring up a really great point, and I'm going to have Bill talk in a second, but transplant for children and adults, it is not just like, you don't just get the transplant and you're done. So there are expenses and needs for years to come that fundraising can really help support, because you never know when you might hit a bump in the road or something happens that you kind of need to access some additional support. So Bill, I'm going to have you share. I'm actually going to stop sharing my screen so everyone can see you guys a little bit bigger. So Bill, can you share a little bit about your story and then your experience with Help Hope Live as well and fundraising?
Sure. So I had like a 20-year journey to heart transplant. My brother died of a genetic heart disease back when he was 27 years ago. Yeah, when he was 27 years old. He was my 6-year older brother, and that started my transplant journey. My condition progressively got worse. I went into congestive heart failure. Of course, I applied for Medicare and disability insurance. So I had all necessary insurance and secondary insurance. When I got to the point of being worked up for transplant, one of the sessions that I went through was financial aid. That's when I was told, it's not a bad idea to do fundraising to cover expenses that insurance won't cover. And Help Hope Live, which is in the Philadelphia area, was mentioned, and I got a pamphlet from them. Of course, I heard of GoFundMe and different campaigns that you can go online and people can set up for you. At the time I was doing my due diligence, there was a lot of bad press about GoFundMe. There still is. There was a big thing in the New Jersey, Philadelphia area about people setting up funds, raising all this money, only to find out it was a big scam and the money never really went to where it was supposed to go, right? So we see those constantly. So in doing my due diligence, Help Hope Live really kept coming to the forefront of this being my choice to do my fundraising. One of the main things was they are a 501c3, which means that they conform to all of the tax implications and laws, right? So it wasn't going to affect my income, because when you do some of these campaigns, it can put you in another tax bracket, and it can really send up red flags here and there. So that was one of the main reasons why I decided to go with Help Hope Live. And the mere fact that they're in Radnor, Pennsylvania, which is my backyard, even made it easier. So I am a Help Hope Live client and also an ambassador for them, because I do advocate for a lot of transplant patients that are currently being worked up or post-transplant, and explain through what my journey was, right? So I had all the necessary insurance. through disability and also secondary insurance with Blue Cross. So I had no problems there. And I just really wanted to do some fundraising because of the expenses of some of the medications that we as transplant patients have to contend with for the rest of our lives, right? We're always going to be on immunosuppressant meds. I did some research, and if I had to pay that out of pocket, we're looking at thousands of dollars a month for these medications, right? So I really wanted to set up a campaign really to cover things that I wasn't really accounting for. And the main one for medicine. And I had a lot of people saying, hey, we want to help you. We want to help you. And I figured, I'm not really one of these guys that posts a lot of things on social media. I'm relatively private. And someone convinced me, listen, if this is going to work, you really got to tell your story, right? So I created a Facebook page for my fundraising through Help Hope Live. We had several fundraisers. Little background, I am an avid cyclist. I'm also a spin instructor. We were trying to figure out, hey, what kind of campaigns can we do that I would benefit from and that people would take an interest in. So we had a spin-a-thon for me that raised a considerable amount of money for my campaign. I love this pizza place in my town, and they said, listen, we can do a fundraiser here where we'll donate 20% of the take for the day to your campaign. They just have to mention your name. And, all of a sudden I had 2 quick campaigns that raised money prior to me having the transplant, right? So again, a lot of people were like, how can I help? And I said, well, listen, I got everything covered, but if you want to donate for unforeseen expenses, I would really appreciate that. So a lot of people rallied for that. And, then I had a comfort level because then I'm talking with other people and they have to drive great distances to come to their transplant centers, all other kinds of unforeseen expenses that insurance doesn't cover. It just gave me peace of mind, right? And in other areas of the country, transplant centers do require that you do some type of fundraising or have some kind of fundraising account available to cover these expenses. So, as I mentioned, Help Hope Live really filled all the checks in the boxes that I had concerns with. And, again, I'm an ambassador for them, a client for them, and I highly recommend them to all of the patients that I advocate for.
Thanks, Bill. So I have one more question for you both before we open to audience questions. So I hear pretty often people, patients and family members say that they feel guilty asking people for money. So, and you really worded it nicely. Like, there's a lot of people who say, I want to help. And this is a great way to, direct way that you can offer them to help. But what would you say to patients and families who might feel guilty about asking for donations?
Yeah, so for me, that was a big thing, right? I just didn't want to be public about anything with what's going on. And, for me to come out and say, hey, I need some help and everything. And, as I had said before, people were just like, how can we help you? How can we help you? This just seemed to be the perfect way. So I overcame that real quick and saw the generosity of all my family, friends, relatives, really coming to the forefront and making a difference, right?
Mm-hmm. Thank you. Yeah, and I think too, the other piece, like you had mentioned, when you have these fundraisers that can be easy, they don't have to be like extravagant things. It's another way for them to help where it's through this fundraiser, it's not like they're handing you cash necessarily, but it's this way for them to support it. And it feels pretty validated.
Yeah. And, I wanted to make another point, Tally, and that's the fact that, the way we are in today's day and age, healthcare laws are constantly changing. You just never know. And it's always good to have that safety net, right? And one of the key things is I realized when I was in congestive heart failure, people knew that I was sick. They could see my limitations, that I couldn't walk very far, I couldn't go up steps. And this is even more how they wanted to help. And I found that if you start your campaign before your transplant, you're better off, because in my case, I had a very successful transplant. Everything went great and I was up and running. Not everybody has that. Some people have some real major struggles, and that's where their campaign can help. But it's much tougher on the back end to ask for money, especially after your transplant, and people can see that you're doing well and they go, oh, you don't need money, but they don't realize all the other stuff associated with all the checkups and, all the travel and everything else associated. So, key piece of advice is, if you are currently being worked up or, pre-transplant, this is the time to set up your campaign. This is when you're going to have the most effect.
I
Yeah.
would second everything that Bill says. And it's just, you have to let them, your family and friends, give it in any way possible to give. And starting beforehand is definitely best when you're at your sickest, and the child is at their sickest. And so, we had a lot of friends and family that didn't know what to do, and they would have given in a heartbeat had they known where to give or how to give. And future looking, like Bill was saying, we found just really weird wrinkles, like in insurance plans, how they're constantly changing, and we're incurring a lot more expense with co-insurance that we hadn't expected before. That's going to continually happen in the future. It's nice to have just that safety net of a fund where you were able to fill that up beforehand and have that available, even if things come up like that you don't expect.
Yeah. And Melissa, now that it's been so many years since his transplant, do you still actively fundraise? Like, how does that work for you guys?
We haven't actively fundraised in a while, but I've been thinking about it. We're all a grateful community. We've been gifted this amazing gift of life, and every moment we have is icing on the cake. And, so we are so grateful. We've considered maybe even fundraising for new transplant families, in a position where they aren't able to do that. So if you do feel that need to give back and do something, all of these organizations have ways where you can give to other campaigns as well, and help new families out that maybe really need it. You can also do things for yourself too. I love the cycling idea. I've got a new Peloton, so I've grown a new affection for that. So I think that's really cool. And we should do some kind of Peloton thing for these groups. But yeah, there's all new ways that we can raise money for new families and for existing ones.
Yeah, absolutely. And, for all of the families that are on and patients that are on today who are post-transplant, like, they should be encouraged and motivated to look into this as well, because again, you never know when there might be concerns. Like Bill said, it can be a little bit difficult when people see you and they think like, oh, you already had a transplant, what do you need from me now? But like you both said, you just never know what can happen, and insurance, everything changes. So it's important to be prepared, especially as it relates to medication. We don't want anyone ever to miss medications or feel overwhelmed financially by their medications.
No, just for context, we have, out of pocket for $10,000 a year, and we know we're going to spend $10,000 a year. And a lot of people are in the same boat as us with, a little more, a little less. So those are the kinds of things that helps. Most people don't hit their deductible for the year, but these families, they always do. And that's an expense that we have to carry around.
Yeah, absolutely. So I'm going to bring Brenda back on, and we're going to go through some questions. There's a lot of questions, some people submitted earlier or through the registration. So I have a few from there. And then also I can see a bunch. I know Medicare and insurance is very confusing. Brenda, are you still here? I know she's here, but she might have had to step away.
Yes, I'm here, Talia.
Hi. No, it's okay. So I'm going to go through the questions and I'll ask each of you directly as they relate to you. So Brenda, really quickly, you had touched a lot on kidney, and I know that you were, when you referenced, can you hear me? Sorry.
I can hear you fine. Thanks.
You referenced other disabilities. Can you just clarify those other disabilities? They are qualified as other organ transplants, correct?
Yes. The disabilities are going to vary. We work with heart, liver, pancreas, and kidney here, but the only disability that entitles you to Medicare right away is the kidney, the ESRD or the kidney transplant. But it's the other disabilities like the heart failure and the hepatitis and the liver, chronic liver cirrhosis, and diabetes. Some of those are the other diagnoses that require the 2-year period to
Okay.
actually see that Medicare benefit once you're actually approved for the disability. Now, getting approved for the actual disability is an event in itself when it comes to Social Security. That could take up to 6 months before you even get an approval for the actual disability. And then the 2-year wait period starts. So it's a pretty trying time. And the
Yeah.
pandemic has not helped at all, getting a lot of these things processed.
Yeah. So for some of the questions that were related to, like, is this just for kidney or for others? So I would suggest going back and rewatching some of this. And when Brenda references other disabilities, that's related to other organ transplants. So liver, heart, lung, pancreas.
Yes.
Kidney, I want to say kidney's easier, but it is just, you need it, you go on dialysis and you get Medicare immediately. And then also Medicare stops after 3 years post kidney, but that's not the same for other organs. Another question for you, Brenda. So can you talk about really quickly Part D prescription plans and Part B as it relates to like the anti-rejection drugs?
Transplant?
A
Sure.
little bit confusing.
Sure. It depends on whether or not a patient had Medicare A or B at the time of transplant to determine who's going to be responsible for the anti-rejection meds. For our patients who opt out of Part B because they have active employer group coverage, even though they have Part A at the time of transplant, the group coverage is covering the anti-rejection med. But because they had A when they were actually transplant, whenever they pick up Part B would be responsible for the first 80% of the anti-rejection meds. Now, if a patient did not have Medicare A or B at the time of transplant, whenever they become Medicare entitled, Part D is responsible for the anti-rejection meds. So it really depends on whether or not a patient had A and or B at the time of transplant to determine who's responsible for the anti-rejection meds.
Okay. And I do want to mention also, this is all very confusing, can be overwhelming, and that's why there are people like Brenda out there. So if you are uncertain or have questions, you should have someone in on your transplant team that can help navigate some of these questions and issues. So I have a question for Bill and Melissa. Someone had asked, like, how do you stay motivated to fundraise if fundraising slows down? So like, you're not getting much fundraising happening, but how do you stay motivated to keep asking and doing things? It's a tough question.
I can answer if you want first. That's why it's so helpful to have that team, because even if you get tired and you aren't thinking of things anymore, I know these organizations, they encourage you to have a fundraising team. So you can always pass that torch to one of your teammates, and then they will be able to start to come up with new ideas and give you a break to focus on your health, or just to give yourself a mental break.
Yeah, and for me, Help Hope Live, you have a support person that helps you figure out different fundraising campaigns based on your interests, hence the spin-a-thon thing with my biking. So they help you brainstorm and develop unique fundraisers, and they're always thinking, right? And in fact, we had a family member that was a baker and she wanted to help, and she had like this bake-a-thon where portions of the proceeds were going to my campaign. So they were always thinking about different angles and revenue streams that I could tap into. So they would constantly keep me motivated with, okay, what's the next thing we can work on, right? So that really helps, as to Melissa's point, to somehow have a team. And that's really what keeps you motivated, because I really passed that off to someone else because I was just so tired. I didn't want to have to deal with it. So a close family friend really took the wheel and, drove my campaign, did everything. I didn't have to worry about anything regarding that. They took care of it for me.
Yeah, that's a really great point about the team, both your support group, like support people, as well as the teams within those organizations. Like, if you think about GoFundMe, there's no one in GoFundMe that's going to support your fundraising needs. And these transplant fundraising organizations are really there to be your contact when you have these kind of questions or issues and can really guide you. So that's one of the reasons why we always refer people, like, GoFundMe can be helpful, but you really need that extra level of support through these other organizations. And that, I have another question about that, which I'm going to hold for a second and ask another one to Brenda. So Brenda, regarding other insurance plans like COBRA, the Affordable Care Act, and well, those two specifically, like if you have COBRA and you become eligible for Medicare, can you cancel COBRA, or do you have to like wait it out? I think you're muted.
That's a good question. If you have COBRA first and then become Medicare entitled, once your Medicare is effective, you no longer qualify for the COBRA. And you have to get the Medicare A and B and the supplemental and the Part D. But if it happens the other way around, if you just happen to be on Medicare and then somebody loses employer group coverage and you're entitled to the COBRA, you don't risk losing your Medicare and you can still pick up the COBRA.
Oh,
But you want to weigh one against the other, because everybody knows how expensive COBRA payments could be. And it's usually going to be much more cost effective to enroll into a Medigap or a supplemental plan to coordinate with that Medicare.
okay. And then how about if you are on a marketplace insurance?
When it comes to marketplace, they no longer force you to drop the individual policy through the marketplace. However, if you're on any subsidy, government subsidy that offset your premiums for that ACA or Affordable Care Act plan, you are no longer entitled to the subsidy. So then you are responsible for the full amount of the premiums of that ACA plan, which is comparable to COBRA. So it really doesn't pay to keep that ACA. Once you get the Medicare, you've got a full 6 months to choose a supplemental plan. Just make sure you get some assistance so you get one that's going to coordinate well with the anti-rejection meds and all the other medical services.
Okay. And then really quickly, can children get Medicare as well? Absolutely.
It would be based on the one or both parents' work history.
Oh, okay. Great. Thank you so much. So much information. This could probably go on for much longer. But in, you know, to be respectful of everyone's time, my last question for Bill and Melissa, as it relates to, Bill, you mentioned this a little bit, but as it relates to like taxes, like that's a thing people don't realize about GoFundMe. So on both sides, can you share a little bit about how it doesn't impact your, you know, income when you get those donations, and then also how people can give money and it be considered a taxable donation through the organization?
Melissa?
Go ahead and start first. It doesn't count against your taxes at all. So it's money raised for the child. So it's in their own buckets. It doesn't go against the family. It's for them when they need care. So our taxes were never affected in that way. If we had done a GoFundMe or something like that, it definitely would have impacted us. And so we definitely don't recommend that. There's just so many advantages to going to one of these wonderful groups and fundraising through them, knowing that the people that come and give money will be able to know they're giving to a good cause and to medical expenses and helping you heal and thrive. So I'm sorry, go ahead.
Yeah, so the same, right? Nonprofit status is key. Being a 501c3, they have to conform to all the tax regulations. All donations are tax deductible donations. They have to account for all that stuff, and they do that for you. You don't have to worry. GoFundMe, if you raised a lot of money, it could actually be looked at as earned income, can kick you into a different tax bracket, could even affect your disability insurance based on that amount of income. The other cool thing with Help Hope Live, and I'm sure it is with CODA, they also do matching since they're a 501c3. So I had people that worked for Fortune 500 companies or even small time companies that said, hey, if you have a great cause and you want to make a donation, we'll match it. And I got a lot of funds from matching donations with companies.
Yeah, thank you so much, Bill. We have to end because it's just a little bit after 5, and there's a lot of questions, and I'm so sorry we couldn't get to them all. So after this, over the next few days, Brenda, if you're willing to talk me through some of the questions, and we can try to
Absolutely.
come up with some resources to send out to people. But I think the most important thing to take from this, and again, there's a recording and you have the slides, is that transplant is unfortunately very expensive, and it can be confusing as it relates to insurance and Medicare and private insurance and all. So please reach out to your financial coordinator and your transplant team. Please consider fundraising through one of these amazing organizations that are really there to support the costs not covered by insurance, to help you through this really overwhelming time. So thank you again to CODA for sponsoring this webinar today. We'll send out an email with resources for all of the organizations, as well as if Brenda is able to answer a few questions, we'll try to send that to everyone. Please feel free to reach out if you have additional questions. Please consider joining our future webinars. And thank you all again for participating today. So have a great night, great day. And Melissa, you're in Arizona, so it's like much earlier there. But thank you again for everyone participating, and hopefully we'll see you next month.
Thank you.
Bye.
Have a great
Thanks,
day.
Brenda. Thanks, Charles.